questions without disturbing Miss Rosenthal.
All right, thank you for that. The one thing I'm going to add to that is that I apologize if you see a black kitty or if you hear him meowing because he's been a nuisance this morning. So just a heads up about that. I apologize. I can't, control him when he's meowing. So let me just get this presentation going, and then you guys can tell me whether you're seeing what you're supposed to be seeing.
Yes.
All right. Well, I don't know if you, but he's being a nuisance right now. So there you go. There's Kitty Cat. Okay. All right, buddy, you're killing me here. All right, everybody's got let me know when everybody's logged into the QR code. I'll probably leave it there for a little bit and then we'll get going. And you guys can hear me okay?
Yes, we
Like,
can.
all right, perfect. Okay. Dr. Mormon, how long do you usually leave the QR code on for everybody?
So actually, we leave them open until you get to the next question.
Oh,
And
okay.
so that first question should already be should be evaluating the respiratory development video, and
Mm-hmm.
it's open for responses, although I'm not sure that anybody can see the question yet because I don't see any responses coming in.
All right. Well, then I'll just move on and then go from here and see. And you can let me know whether it's now, whether the poll's going.
The
Well,
question's now up.
the question's up. I see the poll. I'm logged into poll everywhere, and I see the question as being active. I I don't see any answers coming in yet, but that's okay.
Okay. Well, then I guess you can just let me know when I can just get started, or because I'm
That's
also still seeing people coming in to the waiting room
Yeah.
as well.
We'll wait another minute or so with this question. Actually, once everybody gets into the
All right, somebody needs to be muted. All right, I'm seeing in chat that some
Yes,
people have
I'm
answered.
seeing that too, but for
So,
some
all
reason it's
right.
just not showing up on my screen, which is fine.
All right, then I guess I'm just gonna get going and then we can, if anything else, just kind of flag me down and
Yeah,
let me
you can
know.
go ahead. There are 148 responses.
Okay,
Uh,
fantastic. All right, everybody. Good morning and welcome back to some more embryology. So today we're going to be tackling the respiratory system development. But before we go into that, I think it's always more helpful to kind of go back into a slight review. So I would like you guys to take maybe just like a minute or however long you think you need to just kind of think about these questions, right? We want to kind of reorient ourselves when we're looking at the right hand diagram. That's going to be kind of the top view through the amniotic sac, right? So we've cut the amniotic sac and we're looking down into the trilaminar germ disc. And then the bottom left is the diagram kind of at the dotted line. So if we were to kind of cut the trilaminar germ disc and look at it from the inside, we would see the lower left diagram. So, what are our three main tissues and what are the three subdivisions of the mesoderm, right? We want to kind of rethink about that and reorient. So, if you guys want, you can either put them in chat or you can also like unmute yourselves and answer as well. And let me actually pull up your faces so I feel like I'm talking to people and not just to myself. All right, so I'm seeing Ecto, meso, and endo. All right, so we're going to have ectoderm, mesoderm, and endoderm as our three main tissues, right? We've got ectoderm up at the top in blue. We've got mesoderm in the middle as the red. And then thickening of the neural groove, which is going to become our spinal cord. And then inside of the mesoderm, right in the middle, we have the notochord, which is going to be integrated into our IV discs to kind of cushion our vertebrae. So now, what are we talking about in regards to the three subdivisions of the mesoderm? Kind of like, let's start from the notochord and build outwards. What's the one that's closest to it, right? This one, if you guys paid attention to the actual diagram, it's on the diagram. So when you're looking at the closest one to the notochord, that's going to be paraxial mesoderm, paraaxial right next to the axis, and that's going to be those skeletal muscles, right? So if you guys remember in development, you talked about somites, you talked about muscular development, that's going to be this guy right here, paraxial mesoderm. Then right next to that is going to be intermediate mesoderm, and then we're going to end up having the for that one, we'll leave it for much later in the semester. Actually, I think we're going to talk about it in spring semester. That's going to be more of your kidneys and the urogenital system. And then lateral mesoderm. This is going to be the one that we really want to pay attention to, right? This is going to be the main player in a lot of our upcoming lectures and even in today's lecture. So that lateral mesoderm is then going to end up being separated into two different spots, right? Or two different sections. We're going to have splanchnic lateral plate mesoderm and somatic lateral plate mesoderm. So somatic lateral plate mesoderm is going to mean that it's part of what will become the body of the embryo, versus splanchnic means it is going to be more related to the viscera. So oftentimes when you think about visceral development and mesoderm that contributes to them, it's going to be the splanchnic lateral plate mesoderm, as opposed to the somatic being more like part of the body wall. All right. So then let's talk about these guys. Can you think about, tell me, what is splanchnoplury? What makes up splanchnoplury? Or does this word even sound familiar?
Good morning. I'm not sure, but I think it's maybe a mix of like the endoderm and the splanchnic mesoderm,
It
something like that.
is. Exactly. That's correct. Exactly. So you're going to have splanchnoplury being a combination. So both splankno and somatoplury are going to be a combination. So when you're looking at this diagram again, it's the same view as we had on the previous section. And if we kind of look at the dotted line and we look next to it, you see the notochord kind of right in the middle, and you go most laterally out, and you see that there's going to be this space that is created via apoptosis in between the lateral plate mesoderms, and you're going to have splanchnic and somatic lateral plate mesoderm. And then when you look, you're going to see that one is more associated with the ectoderm, one's more associated with the endoderm. So in the lateral plate mesoderm, you have a space that's going to be created. That space is going to be the intraembryonic coelom. So that intraembryonic coelom is going to become the spaces of your body cavities, your thoracic cavity and your abdominal cavity. That intraembryonic coelom, the space, is what separates your lateral plate mesoderm into a somatic and splanchnic lateral plate mesoderm. The somatic lateral plate mesoderm is going to be found right immediately beneath ectoderm. So somatic lateral plate mesoderm with ectoderm combined together, we refer to as a somatopleura. And then the splanchnic lateral plate mesoderm together with the endoderm beneath it is going to be your splanchnoplura. Okay, so whenever you hear splanchnoplura or somatopleura, it's going to be a combination of two tissues. Excuse me. Now, when you're thinking about the intraembryonic coelom, That intraembryonic coelom is actually portrayed here down in diagram E, and it is going to be horseshoe shaped. Okay, so it's going to kind of run around the lateral and anterior aspect of the embryo. And that's going to play a role when we talk about kind of the formation of the thoracic cavity a little bit later. So those are kind of, I think, the big terms to kind of get familiar with again. The other thing that we want to kind of, make sure we're familiar with again is the folding, because that's going to impact the development of your viscera and your spaces. So in lateral folding, right, you're going to end up kind of tucking in, taking that disc and then rolling it on itself and going from disc pretty much to tube. So if we were to kind of think about this, right, as our disc, our lateral folding, what it is going to do is taking that disc and it's kind of rolling it and creating a tube. Okay, so that's pretty much the lateral folding. And during that lateral folding, you end up kind of creating a tube out of the somatic and the splanchnic lateral plate mesoderms with their surrounding tissue. So you build that gut tube inside and you absorb it internally into the embryo, and that's going to be kind of what's seen here. So you see this yellow right there, that's going to be the gut tube that is endodermally lined. And if we think about kind of the tissues we've seen, then the red that's going to be around it is going to be splanchnic lateral plate mesoderm, right? So now, if we kind of extrapolate from that, anything that develops from that yellow gut tube is going to have mesoderm associated with it, right? Because you can't separate the two. So anything that develops from that yellow is going to then end up also carrying tissue from the red around it. So anything that develops from the gut tube internally is going to be lined by endoderm, and then kind of on the outside externally is going to have tissue derived from splanchnic lateral plate mesoderm. Now, at the same time, on the outside, you right, we see that blue, so that's that ectoderm, and then we know that the red associated with that is going to be somatic lateral plate mesoderm. And when we fold that disc into the tube, we start creating our anterior body wall. So we're going to end up having, right, that tube kind of closing on itself, and it's going to be the anterior body wall. Now, this right here is going to be kind of the position that the paraxial mesoderm infiltrates. So those somites that you talked about during muscular development, the tissue from those somites is going to get into this anterior body wall to form the musculature. All right, Sadaf, I think I'm seeing a hand up. What is your question?
I'm sorry, I'm a little bit lost. Could you please go back to the folding part? And is it possible if you show it again, like how the folding works and how everything gets into the layers in order?
So when you're talking about folding, right, when we're looking at the folding, you're going to end up seeing, right, we've got the red over here, I mean the blue over here, that's going to be ectoderm. Then we're going to have over here, we've got the mesoderm, and then down here we've got the endoderm. Now, when we're talking about lateral folding in the mesodermal area, we're only worried about the lateral plate mesoderm. So we're only kind of thinking about this point over here. Now, if we transition that into the lateral folding diagram, when you're looking at it, we're going to have right this black right here, that's going to be the notochord. So that's going to be this up top. And then our paraxial mesoderm and intermediate mesoderm are going to be kind of in this area right here. So for right now, those two mesoderms we don't really care about. When we then kind of continue more laterally, what we end up seeing is the two separations of the mesoderm, right? You see that there's like one half of the mesoderm that's associated with the ectoderm, right, in this area, right there. That's going to be your somatic lateral plate mesoderm. So if we want to think about the mesoderm plus the ectoderm overlying it, then that area right there we can also call the somatopleura.
Mhm.
Okay. All
Mhm.
right. Actually, I just realized that I shouldn't use SP because somatopleura and splaghnopleura have the same ends, but you get what I'm saying. Now, when you're looking a little bit in inferior, you're going to end up seeing that we've got kind of this yellow right here, and that's going to be the same yellow as the endoderm.
Mhm.
And then you've got the red associated with the yellow, that's going to be the splanchnic lateral plate mesoderm. Okay? Or
Yeah.
the splanchnopleura when we're talking about it together.
Yeah.
All right. So then this space right here and this space right here, that's going to be the intraembryonic coelom.
Mhm.
Okay, so the intraembryonic coelom, remember, is U-shaped or horseshoe shaped. So
Mhm.
that means if we take a cross section like the one that we're showing up at the upper right, we're going to have one leg of the horseshoe on one side and one leg of the horseshoe on the other side.
Mhm.
Okay,
Yes.
all right. So now because we want to go from, right, this disc to the tube, right? We're just pretty much lateral folding. We're just taking one side and the other side and folding it on itself. In embryology, the same tissues, if you have the same tissues on either side, they're going to want to merge together. So what ends up happening is this portion right here and this portion right here, they want to fuse together. So
Uh-huh.
they're going to kind of roll into each other. And when they roll into each other, what they end up doing is they fuse with each other. And then they also encapsulate the tube, the gut tube, that yellow endoderm inside of the body cavity.
Okay, but not all of the yellow will go in, right? Some of them will be.
Not all of the yellow is going to get in exactly because part of it is going to still stay attached at the umbilical area for the next couple of weeks in order to then allow for the GI tract to develop. But we'll talk about that when we get a little bit further ahead.
Thank you
Yeah,
so much.
of course. Okay. So you are all right, so now we see, right, somatopleura on the outside, creating the anterior body wall. We've got splanchtopleura creating the endodermal gut tube that will kind of allow the rest of the organs to develop. And now we have the intraembryonic body cavity that is now starting to fuse to form the spaces that will then allow the organs to develop. Okay? All right. Now, the other thing, right, we don't only have lateral folding, we also have craniocaudal folding. So in the craniocaudal folding, this view, right, if we take the same kind of diagram, instead of transverse cutting it, we're sagittally cutting it and we're looking at it towards the side. So for lateral folding, right, we go from our disc to a tube. And then for craniocaudal folding, we take that tube and then we tuck in our caudal and our cranial end. And I called this the croissant shape. We kind of take the anterior, the cranial and caudal end and kind of like tuck them in. And now we kind of have the body position of the embryo, right? We're going to end up having like the cranial end where the head is going to be able to develop, and then the caudal end where we're going to end up having the sacral region develop. Okay, so why is the craniocaudal folding important? It's going to shift the position of several things. For our section today, we want to pay more attention to the cranial end of the embryo. So initially, when you are like still in the tube shape, you're going to end up first having the future when we're looking at kind of like the tissues that are developing, you're going to end up having the going to end up having the septum transversum. So you're going to end up having some cells kind of like right here that are going to be the septum transversum. Then you're going to end up having the cardiogenic field right after that. Then you're going to end up having something called the buccopharyngeal membrane, which is going to end up becoming your mouth. And then you're going to end up having the portion of the neural tube that is going to become your brain. All right. Now let's think about this, right? In embryology, you end up having, right before you have that craniocaudal folding, from cranial to caudal, you have your future diaphragm, right? So future diaphragm is at the very top, your future heart, your future mouth, and your future brain. Is that how you walk around as an adult? Is your diaphragm above your heart? Is your heart above your mouth? And is your mouth above your brain? If it is, I really would love to see that because that's a darn good paper to publish. All right. So, in order to switch that, we have the cranial aspect that is tucking in on itself. So by tucking in on itself, what it does by this end, by D, we take this septum transversum and pretty much kind of like tuck it all the way inside and reverse this entire order because they're all connected, right? So if this future septum transversum kind of tucks in, it drags everything along with it and pushes things anteriorly. So now all of a sudden, when we look at this right here, the brain, future brain, is the most anterior aspect of the embryo. Does that make sense? If we think about craniocaudal, that now the brain all of a sudden is at the top? Sure hope so. Then the next thing we're going to end up seeing is the mouth. Then we see the heart, and then we see the septum transversum, which now makes sense because we've got the brain at the topmost aspect. We've got our mouth developing. We've got a cardiac tube that is going to give rise to our heart, and we've got the diaphragm that is going to develop from that septum transversum inferior to it. All right. How are we feeling about that? Any questions?
I do have a question.
Okay. Mm-hmm.
So before that, the turning, like before the brain becomes like the most anterior part,
Mm-hmm.
you said that which part is in that place, like before the turning?
So before the turning, you're going to end up having this right here. You're going to have the so if we look kind of at the way that the embryo is in this kind of view right here, you'd have the septum transversum first, which is going to be our future diaphragm. You're going to have the cardiogenic field, which is going to be our future heart. You're going to end up having the buccopharyngeal membrane, which is going to be our future mouth, and then we're going to end up having the brain. Like all of these happen in this small section right here. Like that's the tissues. When you think about the tissues, the cell populations in that area, that's how they're situated. The most anterior aspect of the cells, they're going to become the septum transversum. The next set of cells behind it is the tube of the heart. Next is going to be mouth. Next is going to be brain. If we then kind of go through that folding, pretty much this whole entire area is getting tucked in, right? Because if we're thinking about, we have our tube, and then we've got diaphragm, heart, mouth, brain. When we take that anterior aspect and we go through craniocaudal folding and we tuck it in, now all of a sudden we still have the cells in the same location, but these have been tucked in. So now all of a sudden the one that's left over here is brain. Then we end up having mouth, cardiac tube, septum transversum as the diaphragm.
Perfect. That's so helpful. Thank you.
Mm-hmm. All right. Any other questions about this? I see the chat is kind of popping off. So is there anything in there that I need to address, Dr. Mormon?
We've been covering it as they come up.
Okay, perfect. Thank you. Okay. So now let's transition into how all of this also kind of plays a role in respiratory development. So, right when we're doing the lateral folding, we're going to include the gut tube pretty much from anterior aspect to caudal aspect. So, we have a tube inside of the embryo pretty much from cranial area to the caudal area. In the cranial area, the very first portion of the heart, the gut tube is going to be our pharyngeal arches, which are going to give rise to our face, and we'll talk about them in the following semester. However, at the bottom aspect of those pharyngeal arches, that's going to be arch 4 and arch 6. So just brief overview, pharyngeal arches, there's going to be 6 of them. The fifth one disintegrates. So if we want to number the pharyngeal arches, it's going to be 1, 2, 3, 4, and 6. Between arch 4 and 6, in the floor of arch 4 and 6, we're going to have a small slit. And that small slit is going to be, so if we kind of like take a cross section right at this area, we're going to have our arch 4 over here and arch 6 over here. In between the two of them, we're going to have a slit, and that's going to be our laryngeal orifice. That's going to be the indicator that our respiratory diverticulum is starting to develop. So you've got the gut tube kind of more posteriorly, and out of that gut tube anteriorly, you're going to have kind of this diverticulum that's popping through. So if you think about like the gut tube almost being made of Play-Doh, if you were to kind of stick your finger in between that fourth and sixth pharyngeal arch and kind of push it anteriorly, you're going to drag that Play-Doh, that endoderm, along with the finger and create this respiratory diverticulum. So whenever you hear diverticulum in embryology, you always want to think about kind of an outpouching of tissue. So you're going to have respiratory diverticulum, laryngeal orifice. Laryngeal orifice is going to become, right, that area of the larynx that's going to be open, right? The communication between your future esophagus and your future trachea. And this is going to be the area where your epiglottis is also going to develop. While your respiratory diverticulum is going to become your lungs. Now, the one thing you want to keep in mind to remember is that this respiratory diverticulum, right, is it only endodermal, or is it going to be only endodermal in origin? If we think back to our lateral folding. All right. No, it's not going to be. Exactly. Because remember, around this, you're also going to have that splanchnic lateral plate mesoderm. So if you're going to have this respiratory diverticulum kind of becoming an outpouching of the endoderm, there is no space between the endoderm and the splanchnic lateral plate mesoderm. So they're going to be dragged along together. So the more that respiratory diverticulum divides, the more the splanchnic lateral plate mesoderm divides as well. So it goes hand in hand. All right. So how do we then kind of separate our respiratory diverticulum from our future esophagus, right? If we think about adult anatomy, you have the esophagus and there is one simple communication between the esophagus and the trachea. So how do we do that? So around the 5th week, right, we're going to end up having that respiratory diverticulum kind of continuing to develop anteriorly, and it's going to keep on growing and going to subdivide. Now, posterior to that, you're going to end up forming kind of these two walls. And again, right, remember if you think about what we've just seen, you have similar tissues on either side, they're going to want to come together and fuse. And they're named pretty, I would say, self-explanatory, right? Tracheoesophageal ridge. It's going to be the ridge that is found between the future trachea and the future esophagus. So as the respiratory diverticulum develops inferiorly and starts dividing, these tracheoesophageal ridges are going to kind of grow towards each other until eventually they're able to fully pinch off from the esophagus posteriorly, leaving only one single communication at that laryngeal inlet. Okay? Does that make sense? So we've got the diverticulum, right? So we've got the respiratory diverticulum anteriorly. We've got the esophagus posteriorly. In between the two of them, we've got the tracheoesophageal ridges that fuse together. Okay. Again, also because of the way that the tissues are situated, anything that's internal to the lung, so that internal lining, pulmonary epithelium, everything that's like glandular, that's going to be endodermal in origin. But then when you think about the tissue of the lung, right? Because the tissue of the lung is, and you're going to end up seeing this in the labs if you haven't already, right? The squishy part when you're thinking about the lung, that's you're thinking more of the outside of the lung. That cartilage, the smooth muscle, the connective tissue, that's all developed from the splanchnic lateral plate mesoderm. Okay, so if have you guys done histology of the respiratory system yet? All right. So, right, that ciliated pseudostratified respiratory epithelium, that sound familiar? All right, that's going to be what's endodermal in origin, right? The innermost lining of the respiratory tree, that's endodermal in origin. Everything outside of that, when you're thinking about the connective tissue and the cartilage and everything of that bronchial tree, that's going to be your splanchnic lateral plate mesoderm. All right, any questions about this?
Professor, just
Mhm.
quickly, I know you talk about the splanchnic lateral mesoderm. I'm kind of getting a little confused. Can you show where that is on the diagram?
So in this portion, it's not shown, but if we go back to this view right here, do you see how you've got the yellow and the red that are pretty much right next to each other? There's no space between them. So if out of this gut tube we're going to have a respiratory diverticulum developing anteriorly, it's going to be dragging that red, that splanchnic lateral plate mesoderm along with it.
Got it. Thank you so much.
Sure. Okay. Now, any other questions about this before we get into a little bit more clinical stuff? I'm not seeing anything pop up. So, oh yeah. So I did include this just kind of to show the separation of your larynx and your esophagus. I think it's best seen actually in snakes. You can see how you've got the opening of the esophagus posteriorly, and you've got the opening of the future trachea anteriorly. So this is showing you kind of that really nice clear separation of where the esophagus is posteriorly versus the respiratory diverticulum anteriorly. Okay, so clinical correlates. We're going to, right, you've got two tubes that you want separated. So, of course, there is the possibility of them not separating properly. So when that happens, you can end up with two clinical correlates. One is called esophageal atresia, and the other one is called a tracheoesophageal fistula. So atresia usually indicates some sort of blockage or blind-ended pouch, versus fistula usually indicates that there is a communication between two organs that shouldn't be communicating. So fistula is going to be a type of correlate we're going to end up seeing quite a bit coming up. So it's always going to be indicative that two things that should not be communicating are communicating. So in esophageal atresia, with tracheoesophageal fistulas, we have kind of these five main presentations. A is going to be the most frequent of the presentations versus E and versus the other ones are going to be the rest of them. So there's going to be about 2-3% of each of the rest. The other thing to kind of keep in mind is that if you have kind of this discrepancy in the way that the trachea and the esophagus are developing, you're also going to be impacting the rest of the organs in the thoracic cavity, which means the heart. So if you end up having issues with your trachea and your esophagus developing, in about 33% of the cases, you're also going to have cardiac abnormalities. Okay? All right. So how do we name these and how do they present? So for this one, for A, where it's just called proximal esophageal atresia with distal tracheoesophageal fistula. This is just going to be both proximal and distal esophageal atresia. This is going to, we usually refer to as an H type of tracheoesophageal fistula. This one's going to be proximal tracheoesophageal fistula with distal esophageal atresia. And this is proximal and distal tracheoesophageal fistula. Okay, so you simply take whichever end, proximal or distal, and then you add whatever of whichever one of these two is affecting that particular end. So for me personally, what helps figure out how these are going to present clinically is to kind of draw in what everything is connected to, right? So if we are looking at this right here, right, we're going to know that these are going to be our lungs over here. And again, I'm like drawing with a mouse, so don't judge me on my drawing, but we've got our lungs right here. We're going to end up then having our stomach over here. We're going to end up having our mouth and our noses up at the top over here. So we're going to have our little nose and our little mouth and then kind of connected. Okay. So we've got our mouth connected to the esophagus, right? We're good. Okay. If I eat for the very first time in this first diagram, what's going to happen to that food? If I try to eat, so if food is coming this way, what's going to happen?
You're going to vomit it back up.
You're going to be able to throw it right back up, right? Because there's no way for that food to end up in the stomach because these two parts of the esophagus are not connected. So this right here, usually when you have a proximal esophageal atresia, you're going to end up with projectile vomiting, okay? Because food's going to go in, it's not going to be able to go through the entire esophagus, and it's going to be spit right back out. Then at the same time, when we look further down here, right, we see that we've got a tracheoesophageal fistula between the trachea and the distal part of the esophagus. So what are two things that we might be able to see in this area right here?
You could see air in the stomach.
You're going to be able to see air in the stomach, exactly, right? Because on first breath, you're going to end up sending air into the lungs, but at the same time, there's this connection right here into the stomach. So oftentimes, the babies that are going to end up having this setup of a tracheoesophageal fistula and esophageal atresia, what's going to happen is when they're born, usually with the first kind of cry and deep inspiration, they're going to have abdominal distension because that's going to send air into the stomach and the lungs. And then upon first feeding, they're going to end up having projectile vomiting and having a slight film around their mouths. The tracheoesophageal fistulas in this kind of setup also will present with polyhydramnios. I don't know if you guys have heard about that yet. If not, we'll talk about it also with kidneys. But usually babies are going to need to ingest the amniotic fluid and kind of pass it through their system to ensure that a lot of the organs are set up properly, the kidneys are set up properly. So if you have an esophageal atresia, the embryo or the fetus is not going to be able to drink the amniotic fluid, and therefore there's going to be an extra accumulation of amnion. So you end up with polyhydramnios. The other thing here that is going to potentially be a problem is that sometimes you can also have gastric juices go up through this tracheoesophageal fistula into the trachea, which then ends up irritating the respiratory tissue and can potentially lead to, oh God, why am I blanking? Why am I blanking? Somebody help me here. It leads. I'm blanking on the name, and I'm sorry for that. It leads to inflammation of the lung tissue, pretty much. Um,
I was going to say choroid plexus.
Sometimes when you get gastric juices going into the lungs, you get a little bit of like a pleurisy and inflammation of the pleural lining on the
Oh
inside.
yeah,
Yeah.
yes. Yeah, so that's part of it as well. Thank you. But yeah, so it just leads to inflammation in the area because if you think about it, right, think about gastric acid and now insert that into your lungs. That's not a good combination. That's going to lead to irritation and coughing and inflammation. Okay, so do those kind of make sense? Being able to trace kind of where things are going and knowing what things are associated with what organs. Can you kind of work your way through each one? All right. So now I would suggest for you guys, I'm not going to do all of them because we're already kind of running short on time, but I would suggest doing every single one of them in that way, kind of attaching, right? Remember if it's a lung or if it's the stomach associated with it, right? Nasal passage or your mouth, and then kind of figuring out how things may present. All right. So for the development of the lung tissue, again, we've kind of talked about this before, but this is just a different presentation of, and I think I saw a hand.
Yes, Dr.
Mhm.
Rosenthal, I did have one question about the
Sure.
prior slide. I know we're limited on time, so I'll make it
Mhm.
quick. What is the true difference in clinical presentation between C and E? Because I
Between C and A?
E, E, E.
C and E, C and
Yes.
E. Yeah. So in C and E, the big change is the fact that you see right here
Mm-hmm.
there is still a little bit of space of the esophagus where it communicates with itself. So in this case, the food has two areas that it can go into. It can some of it can go down into the stomach and most of it can go down into the trachea just because of the way that it's kind of positioned. So there is a communication between the esophagus and the stomach. So if you look in the stomach of this infant, you'll see both air and food. They'll also have a little bit of a weight gain.
Mm-hmm.
Not much, but there's going to be some weight gain. When you're looking at in E, you're going to have air in the stomach, but you're not going to have any food because there's no way for the food to kind of go into the trachea this way and then kind of backpedal and go out that way.
Okay. I
So
knew
there's going,
because they were so tiny, and it's so
yeah.
close that it might hit a
So
U-turn.
Yeah,
Okay.
so it's much because you again you have to think about how this esophagus is situated in gravity and right most of the
Mhm.
food in infants being fluid, so it's not going to kind of backtrack. It's going to just go with gravity and go much more into the lungs than up in C.
Thank you.
Mm-hmm. All right. So for the tissues, right, this is a little bit better kind of visual, I think, for how the space is going to be created and where the tissue comes from, right? So in the yellow, we have that endoderm that's going to give rise to our respiratory diverticulum, our trachea, and our respiratory aspect of the lungs. We're going to have the splanchnic lateral plate mesoderm along with it. So how that trachea develops, it drags that tissue with it. And then we have this space, which is the space inside of our thorax. And then outside of that, we've got the parietal pleura, which is going to be the external lining of the thoracic cage. And that's going to be your somatopleura. Okay. So that's going to be kind of the development of this right here. And how it correlates to adults, right? We've got our lung, which is going to be created from that, right? The respiratory tree is endodermal. We've got the lung and the visceral pleura being from splanchno pleura. We've got the space, which is the thoracic cavity. And then we've got the parietal pleura, which is going to be the somatopleura. All right, so then stages of lung maturation, right? We're going to end up having four main stages to focus on. This is going to be one of those where you need to pay attention to the numbers. So, right, we've said that there's going to be specific times where you have to pay attention. This is one of them. You have to know when the stages start and end and kind of what's going on during those stages. So the pseudoglandular stage is going to be from week 6 to week 16. Respiratory diverticulum starts developing around week 5, and then from 6 to 16, pseudoglandular. This is going to be where we have our bronchial buds kind of continuing to subdivide and subdivide until it becomes terminal bronchioles. In canalicular, it's 16 to 26. And this is going to be where we have those terminal bronchioles becoming alveolar ducts. 26 to birth is going to be our saccular, where we've got our alveolar ducts kind of starting to set up our primitive alveoli. And then we also have our pneumocytes that are starting to develop. So type 1, type 2, we set up our blood-air barrier and we start creating surfactants. And then we've got alveolar, which is going to be 32 weeks till about 8 years old post-birth, right? So we're going to end up with these stages. You have to think about them kind of how we discussed the placenta, right? So remember in the placenta, we had primary villus, secondary villus, tertiary villus, and it wasn't a we're all primary and then we switch to secondary and then we switch to tertiary. It's going to be a transition. So you may have part of the lungs right at week 16. You may have part of the lung that is still in the pseudoglandular stage and then the other part in canalicular. And there's a transition period between them. So you're always going to have a little bit of a lag of the previous section. The two things to kind of pay attention to are saccular and alveolar. Saccular is going to be where you end up having later in the saccular period is where you end up having the ability to breathe and survive on your own. So that's why when there are high risk pregnancies, oftentimes they're going to try to push as far past that week 26 mark as they can in order to ensure that the neonate can breathe on their own. You need that surfactant to be produced in order to allow for proper breathing. The other thing too is that you have this alveolar period that goes pretty much until you're about 8 years old. So that means that a lot of your lungs are developing while you're growing. And when you're born, you have about 50 million alveoli. By the time you're at 8 years old, you've got about 400. So, in this case, you have to think about the environment that the baby is going to be in, right? If you have an environment that's full of smog or pollutants or secondhand smoking, then you are at risk of improperly developing those lungs because you have, right, the child is inhaling all of these irritants while their lungs are still developing. So, you're at much higher risk of developing asthma and other respiratory issues if, as a child, within the first 8 years of your life, you're exposed to an environment that has these irritants. All right. So clinical correlates, right? Respiratory distress syndrome. This was used to be known as hyaline membrane disease, and it's due to the lack of surfactants. So pneumocytes 2, hopefully that sounds familiar from histo, are what develop your surfactant. You need surfactant in order to be able to ensure that your alveoli are going to be able to expand after the first exhale. So if you've ever, I don't know if they still do this in school, but if you've ever done a surface tension experiment where you have like two glass slides and you put them together and you try to pry them apart, usually you can't. They're like suctioned together. But if you take a slide and put a drop of water on it and you put the two together, now all of a sudden you can roll them off of each other and pry them apart a lot easier. So that liquid separates the surface tension. That's exactly what surfactant does in your lungs. When your sac expands upon first breath, if you don't have surfactant, when you exhale, that sac collapses on itself. And you will not be able to introduce enough pressure to open it up again unless there is a surfactant in between the walls. So no surfactant, unable to breathe. Surfactant, able to breathe. This is also, if you've ever heard preemies getting corticosteroids or getting injections of surfactant or any of that sort, it's due to this respiratory distress syndrome that they're trying to tackle. So usually for the corticosteroids, they're trying to make sure that you've got the inflammation down in the lungs, and then they're given surfactant, it's to try and keep those alveoli pretty much lubricated to be able to breathe on their own after. Next up, we've got pulmonary agenesis. That's just the lack of the development. So when you're talking about respiratory diverticulum, part of it just doesn't separate. So you end up maybe with one lung on one side, or you end up with no lungs. Then you can have abnormal division of bronchioles, which can lead to an abnormal number of lungs lobules. This one right here is not really a big problem. The way that your lung is really separated is not, it's not going to really matter as much as if you have the rest of the clinical correlates. Congenital cysts, in this case, you end up your bronchi and your alveolar sacs expand so much that they're literally not able to have that blood-air barrier, and they're not able to exchange gases. And this one usually has a very honeycombed appearance on a histological slice. And then ectopic lung lobes is pretty much you've got an extra lung that develops somewhere. This is the respiratory diverticulum doesn't develop in the proper place, or you have an extra one that kind of develops beneath it. All right. Septum transversum, all right, this should hopefully also be a review because you talked about diaphragm development, but again, this is just kind of focusing. Initially, you start with the septum transversum at the very anterior aspect. You go through craniocaudal folding and you bring it inwards and you create that diaphragm, and you end up having your diaphragm with the somites of C3, C5. And you end up having the pleuroperitoneal membranes from the posterior aspect growing anteriorly to create the diaphragm. So if you go into this view, you've got your septum transversum right here, and those pleuroperitoneal folds come from the back of the embryo to kind of fuse together to fully form the diaphragm. The big problem with this is that the left side usually lags behind in development and sometimes doesn't fuse. So what that leads to is diaphragmatic hernias. So in the embryo, there's very limited space. And because of that, right, whenever organs are developing, they're going to find whatever space there is. In the case of a diaphragmatic hernia, the GI tract is also developing at the same time. So the GI tract is going to look up, see that there's a space open in the thoracic cage, and pretty much make their way up into the thoracic cage, which then ends up shifting both your respiratory and your cardiac structures towards the left side. Towards the right side. which impacts the development of the lung, can impact the development of the heart. And depending on how bad this is, you have about a 50-50 chance of survival. Um, However, the ones that do survive, you have a good chance of pretty much reaching adulthood and living a perfectly normal life. We've had, I think a couple of years ago, we actually had a donor in Middletown that was 102 years old and had a diaphragmatic hernia just like this. So it can be just fine once you do survive. All right, and then thoracic cavity, right? So first off, the diaphragm separates your thoracic cavity from your abdominal cavity, but then you have to separate inside of the thoracic cavity from lungs to heart, and that's going to be the pleuropericardial folds. So when you're looking at the pleuropericardial folds, they're going to be separating that thoracic cavity for cardiac space anteriorly and pulmonary spaces posteriorly and laterally. So that's better seen in this view. You've got kind of these sides right here that are coming together. You're going to end up having your lungs kind of developing posterior and laterally, your heart developing anteriorly. And then as things kind of move along and the lungs continue to develop, they kind of wrap around laterally and anteriorly while the heart gets pushed slightly posteriorly. All right. And I think that's it. I'm going to stop there. The questions are included in the PowerPoint. You can run through them. I have included, I think, in the notes, some of the answers, so you can double check that. And then if you have any questions, you are more than welcome to email your faculty to answer them. So let me see, what is 20, what age can premature babies survive off of artificial surfactant? Yeah, so that's going to be, it's a little bit contested depending on what books you're looking at and what what physician you're talking to. Up until about 15 years ago, they wouldn't. I think that the line was drawn at saving preemies at 25 weeks, and I think nowadays, because of the advancement in treatments, some will go all the way down to like 23, 22 weeks. However, and that's like the last JAMA article that I saw. But
Yeah, no.
however, it's that one is at like you have to involve the family, you involve the doctors, you have to have a briefing with everybody. The chances of making it to adulthood at 23 or 24 weeks, I believe, is 1 in 900. Like that's the chance of survival without any impairments. So out of preemies born at 24 weeks, out of 900 preemies born at 24 weeks, only 1 in 900 reaches adulthood without any types of impairments. And that's after about $1.5 million treatment while they're in the NICU, which can last about almost close to a year. So first couple of months full time in NICU, and then, weekly visits to the hospital for the first year and a half. And yeah, about a million and a half last time I checked the numbers for the first year. So yeah, hopefully that gives you a little bit of a
Those are specialized centers.
yes,
You're
yes.
not having a birth on the fly that, oh, I'm having it premature, I can't get. These are well established in the hospital, high risk cases.